So it's a pleasure and a privilege to introduce the speakers for the Taking Action, Next Steps to Reduce Disparities and Improve Quality panel. So finally, we're getting to our action segment of the day. In speaking about action going on right now, as you're going to hear, in major health systems in the country, it's remarkable to me that Dr. Wisdom, Dr. Siegel, and Dr. Sandy will be talking about the work that was first called out in the Heckler Report. So I went over and read not the whole report. As you heard, it was quite long. But the exact kinds of things and your problems, your challenges, your solutions resonate today exactly the way they did 30 years ago. I found that striking. So this includes developing and implementing educational campaigns to engage persons with language, culture, or communication barriers, to understanding health risks and resources. It includes examining and adapting the way healthcare is delivered and financed to meet the needs of vulnerable populations. Believe it or not, there's a section of the Heckler Report on healthcare delivery and financing. Developing and diffusing new models and programs, and partnering with community and faith groups to improve access to care. So while many of the priority health conditions and strategies that were called out in the Heckler Report 30 years ago have not changed, showing that we're still on this journey, we have made some progress in several ways that I'm noticing. That report, they really struggled with understanding. They didn't have the data that we have today. So we've made big progress in our improved ability to use data to create specific performance targets and to benchmark our progress. That's just my own observation from that report. We also have much more information about what works, interventions that work. 30 years ago, we had a big hole in that area. However, one thing that was striking was the Heckler Report stated, advances in diabetes and hypertension will no longer need to lead to premature death and disability. We know this has not come to pass. Indeed, we have a lot more work to do. So I want to turn this over now to three equity entrepreneurs, as I'm going to now knight you, who will share their work that is lighting a path forward. Dr. Kimberlydawn Wisdom, Senior Vice President of Community Health and Health Equity for the Henry Ford Health System. Dr. Bruce Siegel, President and CEO of America's Essential Hospitals. And Dr. Louis Sandy, Senior Vice President for Clinical Advancement in the UnitedHealth Group. They have very large, long bios, and I would love for you to take a look at those. They're in your packets. Thank you. So with that, I'll turn it over to Dr. Wisdom.
Great. Thank you very much, Ms. Shea, and I'm very delighted to be here. I really appreciate the invitation from Dr. Kara Jones and the Office of Minority Health, and really want to celebrate with you the CMS's 50-year anniversary as well as the 30-year Heckler Report. Very, very impressive. Also, I feel so appreciative of the Heckler Report, particularly my career was beginning to move forward around addressing we called minority health issues 30 plus years ago, and the Heckler Report actually gave some lift to that work because it's over the many years has been certainly very heavy lifting. I want to share a bit about, well, for one, I just want to say, I'm also celebrating on another level. I'm finally, as of 7 p.m. last night, when my third child drove off to his job in Grand Rapids, Michigan, I'm considered now, my husband and I, official empty nesters. So all the little little wisdom owls are officially gone, and we are on to a new venture. So that's also an area for us to celebrate personally. But I want to give a perspective related to some of the work that we're doing at Henry Ford Health System in particular, and how we have been informed by many of the reports and much of the work, of course, that has been occurring at CMS in order to move our work forward. Just quickly, Henry Ford Health System is led by Nancy Schlichting. She's a Baldrige Award. I have no conflicts to disclose. a Baldrige Award-winning CEO. We have she runs a $5 billion company. We have about 23,000 employees. We have a health plan. We have about 1,200 employed physicians, another 2,200 private practice physicians, and about 23,000 employees. So we're a very large integrated model, and but someone mentioned earlier today, leadership matters, and under Nancy Schlichting's leadership, and soon to come Wright Lassiter III, her successor, as well as her Nancy Schlichting's predecessor, Gail Warden, the leadership, I cannot underscore enough the importance of leadership in driving these efforts forward, because they actually gave entree to much of the work that we have been able to do. I also want to say we serve a very, very diverse community. We have a large African American community, very large Latino Hispanic community, as well as the second largest contingent of Arab Americans outside of the Middle East are in Detroit, a large Bengali and Yemen. So very, very diverse community that we serve that continues to challenge us to serve in better and better ways. And just this year, we did receive the American Hospital Association Equity of Care Award, and I know Tomas is here from AHA. We're very delighted to receive that. Also #1 in Diversity, Inc. for healthcare systems, as well as the Healthcare Equity Index Award that addresses the needs of our LGBT community. But it just means that we're moving in the right direction and still have much to do. I want to say that our vision, and I'm going to talk quickly because I know my time is limited, is transforming lives and communities through health and wellness one person at a time. And we went through a major process to come up with this vision, and it was voted on by our employees, but it's something that we really embrace significantly, especially in terms of transforming, because we believe Henry Ford Health System, this is our 100th anniversary, our centennial year, and we have pride ourselves that Henry Ford himself was an innovator. So we often say that innovation is within our DNA. So transforming, we're not talking about making incremental changes. We truly have a spirit of transformation and attempt that in all that we do through our work. What's fortunate and has helped really propel our work forward is that Nancy Schlichting and her vision around performance management and strategic direction actually established as part of our strategic framework a community pillar. So that pillar, along with finance and people, our HR pillar, service, quality, and safety, we call it community pillar is weight-bearing and accountable, which means we have board reportable goals and expectations, and we have to develop a strategy around that. So having that actually drives our efforts up to the very top of the organization, which has been very key in advancing our equity work. Also, what's interesting, I also, as of about a year ago, served not only as leading our equity efforts, but I was appointed as Chief Diversity Officer also. And the beauty of that is the equity and diversity are inextricably linked in many respects, because it takes, certainly diversity embraces the differences and inclusion, but equity ensures that those differences are mitigated. But they work hand in hand in the sense that you have to have a diverse workforce that looks like the community that you're serving if you're truly going to address racial and ethnic health disparities, as well as the other disparities that we heard about earlier today. Back in, it's been a very long journey for us at Henry Ford Health System, but in 2008, 2009, we began to very much structure our efforts around a serious commitment around healthcare equity. I had just served with Governor Granholm as Surgeon General for the state of Michigan for 8 years, and Nancy Schlichting invited me back. I had been serving as an emergency medicine physician and doing research and teaching at the University of Michigan's medical school, and when she recruited me back after serving in that governmental post, I said, Nancy, we have to be very, very serious about equity if I'm going to return, because I really want to move this work forward, and I'm going to have your full support on every aspect. And she wholeheartedly agreed to that. So coming out of the political arena, of course, campaigns were something that resonated with me. So we thought we would conduct a healthcare equity campaign that really would help us align ourselves as an organization, particularly in the city of Detroit, which has had a history of racial challenges over many, many decades ago, and we knew that it was going to be a heavy lift for the organization. Also, I want to underscore the word care, because we know that health occurs where people live, learn, work, play, and pray. However, we didn't want the providers, the physicians, the other healthcare providers to feel that we can't address equity because we're providers. We can't address poverty or social determinants of health. Those are too big for us to address. But when we underscore the word care, we felt this sits right in the center of what you can do. You can assure that our screening rates are much improved. You can ensure that you have a different conversation with an individual that's never had a screening mammogram or a prostate exam before versus someone who gets one all the time. So we felt we are really speaking to the providers, the researchers, as well as the community in terms of we have to all work together to address and eliminate certainly racial and ethnic health disparities as well as those affected by disabilities and sexual and orientation as well. The goal of the campaign was to increase knowledge and awareness and also to ensure that people understood the importance of equity enough to begin to integrate it within their practice, not to just know it intellectually, but know it in the delivery of care services, and also to ensure that equity was a key element of clinical quality. We wanted them to definitely link quality and equity, and that's where we got quality and equity are two sides of the same coin. You cannot have one without the other. They are inextricably linked. So we partnered very much, I partnered with the chief quality officer. I said, you need to be my co-partner on this campaign. Nancy Schlichting, our CEO, was the honorary chair, but I said this has to be the two of us together managing this effort. So also just to give a context, the Healthcare Equity Campaign had 3 phases. 1 was to raise the awareness. 2 was to begin to address training and providing tools for people to help them with cross-cultural patient communication. And thirdly, we wanted to begin, the 3rd phase is the longest phase of all. We wanted them, individuals, to be able to integrate equity into their work ongoing, in an ongoing way and a sustainable way. So we've also aligned it very much with the triple aim, better care, better health at lower cost. So I'm going to walk through what we've done in each of those arenas as well. To start off with the better care or improving the patient experience of care, the collection of race, ethnicity, and primary language data was very key. We're moving more into the realm of religion, sexual orientation, that sort of thing, but this is all self-reported, standardized collection of this data at all of our business units, at every point of service, which are over 100 within our system, and in a way that the CSRs or the registration clerks are trained in how to collect this data based on, of course, Dr. Siegel's wonderful work with HRET and helping us with toolkits to help ask the questions the right way. Also, we launched an effort called We Ask Because We Care. We didn't make that up. We actually, GW, we borrowed it shamelessly from other entities and the Robert Wood Johnson Foundation Aligning Forces for Quality. We borrowed the concept. We developed questions that were very specific to our community. So we do have one related to race and ethnicity, related to our Arab American and Chaldean population. And I just went blank for a moment. But, it's up there. Okay, good. Well, I'm glad I have the slides in front of me. But I do want to mention how leadership, again, is so important. Because in collecting this data at the point of service in a very racially charged community in many respects was not easy. Also, at Henry Ford Health System, we were also, at the time we were beginning to implement this, doing front desk redesign and how to collect, information from people from a financial standpoint. So there was a lot of challenge and a lot of pushing and tugging, like, you want the CSR or the registration clerks to collect one more thing? Really? So that's where we went up to the very top of the organization and were able to have conversations with the CFO and the chief quality officer and say, this needs to happen. And they said, we agree and we will ensure that it happens. And it took that kind of impetus to really drive it and not have it delayed unnecessarily. Is it? I'm not able to see it on the monitor in front of me, so. Well, it looks like somebody else's slides are there. Well, I'm just going to keep, in the interest of time, plugging away. And is that? Yeah, that's yours. Okay. I just can't see it on the monitor. Okay, improving patient experiences of care. I'll just keep marching through if someone can ensure that my slides that I'm on, speaking on the right slide. Improving patient experiences of care. Also, reviewing the metrics of race, ethnicity, and language data were very important. Also, likelihood to recommend. So when we look at Press Ganey scores, look at those scores. We're beginning to look at those scores stratified by race and ethnicity. Also, sending patient experience surveys in their native language. And also when there's a grievance or there's been a challenge that needs to be addressed, if it's around language issues, it's important to send them a correspondence in the language that they're comfortable with and that they want to receive health information in. Also, rounding experience by all leaders. We call that real rounding, where it includes us as senior leaders. We're expected to round with various teams across the various business units on a regular basis. And with that rounding, we focus our efforts on those with limited English proficiency and the deaf and hard of hearing, and address spiritual and cultural and religious issues during that time. Also, in implementing our EPIC, we have our electronic medical record. We have a patient portal called MyChart, which many may have a patient portal in that respect. And we're finding while people that are racially and ethnically different may get the code and actually access MyChart, or sign up, enroll in MyChart, they're not accessing it on a regular basis. So again, that digital divide and the ability to access services is limited if individuals are not prepared to make their appointments, receive their prescription refills through that mechanism. Also, a video was developed on how to ask about race, ethnicity, and primary language. In the interest of time, we don't have the time to show that, but it is accessible on this link, and of course the slides will be accessible to all of the people present here and those listening. We have very deliberately developed dashboards where there are metrics that we are reporting to our board. We have an equity dashboard, and from a diversity standpoint, we also have an HR dashboard and a supplier diversity dashboard. And I don't have the ability to talk about our supplier diversity effort today, but we're looking at equity across all of those three domains. You'll see a sample of some of the dashboard measures that we have, whether it's looking at 30-day readmissions, and we're beginning to more and more stratify by race and ethnicity, and whether it's our diabetes bundle, ideal deliveries at least at 39 weeks for our population. So we're having metrics and accountability that are very, very much integrated into the work that we do. Also, we're integrating our equity efforts into our programs and policies. So for instance, we have many awards that we give to various individuals within the organization or on behalf of the organization. We have equity integrated within that. We have many leadership academies, physician leadership academies, new leadership academies, advanced leadership academies. We ensure that they have a day of training in those monthly sessions where they learn about equity and diversity and how to address it within their particular practices. Also, part of our integration effort, we have most recently instituted a healthcare equity scholar program, where initially it was funded by Association of American Medical Colleges, AAMC, through a $10,000 award. Starting last year, in 2014, we enrolled 20 individuals in that Healthcare Equity Scholars Program. They each had to spend, it was an immersion program, they spent a day, a month in learning. They had to develop a project, and then they had to have a time where they could talk about that project. That project is very much integrated in what they do in their particular clinical setting. So this is not something that they're doing separate from their work. It's work that is very much integrated in what they do every day. And also we have an effort to assess how we stand in every single business unit across our organization related to the class standards. So we're taking a deep dive and interviewing and assessing where we are and how we're improving more and more in our class standards. Improving health of populations. As part of our 501c3 tax-exempt status, we are required to conduct a community health needs assessment, a CHINA, and actually develop an improvement plan. And as you can see here, we have outlined, and this is through the data, that we have identified what our priority populations are, and of course you see the underserved, racial and ethnic minorities, and infants, as well as health concerns you see there on the slide that we're addressing in that respect, better health, and really taking a population health approach. Also in the city of Detroit, we're responding to the need I want to say that in Detroit, on average, we have about 200 infants that die before their first birthday. So we have a very, very high infant mortality rate. So we've initiated an effort, of course, it came up on our community health needs assessment, an initiative to address that. And we developed a project called Sew Up the Safety Net for Women and Children to link a community health worker with underserved women in 3 neighborhoods to drive down that infant mortality rate. The women in the community didn't like the word sew up the safety net. They're like, what are you sewing up? Is this a quilting club? This is not very clear. So using our community-based sort of participatory approach, we rebranded it with their involvement, and it's now called WIN Network Detroit, Women Inspired Neighborhood Network Detroit, where we are, again, working with community health workers to drive down the infant mortality rate. Of the women that have been involved, we've had 0 infant deaths to date, and these are neighborhoods that typically have 22 to 23 infant deaths per 1,000 live births in those neighborhoods. So we're very, very pleased with the effort, but we know that to drive down health disparities in those neighborhoods, we definitely have to, the community health worker model has been key. I want to say that this community mosaic mural is called Expecting, and actually one of the grants that we received from one of our funders, actually Kellogg Kresge, the Robert Johnson Foundation, have all funded us in this infant mortality reduction effort. And we thought we would draw murals on some of the buildings in each of the 3 neighborhoods that we were working in. Well, we realized that many of the buildings are being deconstructed or demolished, and the mural probably wouldn't last very long. So we decided to take another approach, and that is to develop a mosaic mural. So we work with an organization called SNAP, and each of these, this picture represents 5,000 small pictures or small tiles, actually of drawings by the community, by board members, by physicians, by members in the community. And the SNAP organization put these together, and it represents where we're going in terms of expecting the best. The 3 houses represent the 3 neighborhoods. The 4 butterflies represent the 4 competing health systems: Henry Ford Health System, Detroit Medical Center, Oakwood Healthcare, and St. John Providence. There's been some acquisition and realignment in Detroit. But those 4 health systems that we compete came together to establish this effort to reduce infant mortality. But I would also say that the larger vision is how can we, being an afternoon speaker, oftentimes the wonderful, great ideas have already been shared, so we thought we'd share something a little more innovative in terms of an approach to take. And part of our vision has been to, if there was in every state and territory in the country, a state-level Surgeon General that could help drive down health disparities and be accountable and be that voice that would help drive down and eliminate, move toward the elimination of racial and ethnic health disparities and disparities related to sexual orientation and disabilities as well. And also address emergency preparedness. So that's just a thought that someone in that position could be accountable and use that bully pulpit to really help drive down and eliminate racial and ethnic and other health disparities. As I get ready to close, I want to mention that how key the community health worker model is, and it's been incorporated in several entities, as you can see here, in our emergency departments, diabetes care teams, but most interestingly, we're getting ready to launch group prenatal visits for pregnant women, all of the same month, gestational month, and they will come together for an hour, 2 hours over 10 sessions, and share. They'll have their visit. They'll also learn how appropriate breastfeeding practices in order to not only reduce the infant mortality rate, but help these women to be healthier overall and also more self-sufficient as women. So we're really excited to begin to launch that initiative. We're also working very closely with our Michigan Community Health Workers Alliance and the state of Michigan in order to have this community health worker model, this different provider type, actually funded, and ideally through plans or through CMS as a sustainability mechanism for these groups. And in terms of lower costs, part of the triple aim, we're looking at all kinds of ways to address lowering costs so we can redirect funds to individuals or to entities, programs that would help with the elimination of racial and ethnic health disparities. And we've also engaged through our diversity arm, employee resource groups, or ERGs, that actually have been very instrumental in giving us recommendations in terms of how to best serve very diverse communities. As you can see, our Pride group, our LGBT group, African American, Latino, our Generation Y group, our younger millennials, as well as our women. And again, efforts to reduce disparities. And lastly, you've heard of the triple aim, of course, better hair, better health at lower costs, but we've also, when we know within the IOM aims, equity is embedded there, but through stakeholder health, an entity that's led by Gary Gunderson, we wrote up actually the quadruple aim, a fourth aim, and actually to elevate the equity aim very deliberately in order to be most successful. So our journey continues. My last slide. What's right about America is that although we have a mess of problems, we have great capacity, intellect, and resources to do something about them. And that's a quote by our Henry Ford himself. And we truly believe that. And we also believe a quote by Ralph Waldo Emerson. It does not matter where the path may lead. You know, go forward and basically make your own path and leave a trail. And that's what we're doing. We're trying to continue to get lift through various efforts, but also we may have to continue to pave new trails in order to have be most successful in the long term. Thank you very much.